First is that we should have a multidisciplinary team approach. That's very, very important. Whether it is a surgeon or a physician, nurse, therapist, dietitian, diabetes, educators, social workers, all of us, if we work together, then addressing obesity becomes easy, and managing comorbidities becomes easy, identifying factors that lead to obesity and identifying behaviors that contribute to maintenance of obesity, and identify needs for intensive interventions and individual sustainability or suitability for the same. And monitoring and follow-up is so very important, because we can speak for 30 minutes, 40 minutes, counsel a patient, bring them into our, understanding. But if we do not follow up, majority of them do not, have a proper weight loss. So there should be review at least in the initial phase monthly, and later maybe every quarter. And prevention, of obesity or reduction in weight leads to so many important changes in their life, especially managing comorbidities like management of dyslipidemia, type 2 diabetes, pulmonary disorders, blood pressure, osteoarthritis, and psychological disturbances. All these are controlled, or rather their risk is reduced if you're able to treat an obese patient and help them lose weight. So current guidelines tell us lifestyle modification is the base, right? Anybody who's newly detected with diabetes and slightly overweight or obese, normally doctors or diabetologists don't start them with medication. First, what they do, they tell them to lose weight, correct?
Doctor, you're not audible.
% of weight loss will help them. Yes?
Yes, doctor. Now I can hear you.
Okay. So when we talk about lifestyle modification, it's dietary intervention. It could be calorie restriction, behavioral intervention, and physical activity. All of this is part of lifestyle modification. And one more thing which we normally advocate is meal replacement also. But in general, if a patient is normal without any problem except for his weight, we may not initiate on meal replacers. But if in case he has a problem in hand, it could be, infertility. It could be waiting for, transplant donation, or it could be comorbidities along with obesity. These are indications where meal replacement can come in handy to help them restrict their calorie intake. So lifestyle and behavioral changes. Lifestyle intervention should encompass 3 areas. One is nutrition and eating behavior, physical activity, sedentary behavior, and psychological behavior. All these together will help them reduce weight. When we talk about nutrition and eating behavior, maintaining a food diary is very important. Eating slowly and mindfully. It is very, very important that they are mindful on what they pick. Decreasing foods that are high in energy, especially the junk foods, foods with added sugars, solid fats, saturated fats can be reduced. Increasing the quantity of food which are low in energy, like vegetables, legumes, grains that are whole. Whole grains have more fiber. Obviously, your intake will come down. And fiber-rich foods. This is a beautiful plate which shows how you can advocate this. Half a plate of vegetables and, salads, quarter plate of the protein, which can be non-vegetarian or vegetarian protein, and quarter plate is the whole grains. So that way you restrict on the carbohydrate content of the plate. Avoid snacking in between and skipping meals, because skipping meals, especially breakfast, can lead to obesity. Same way, late night eating or nocturnal eating can also lead to increase in weight, and it increases insulin resistance. And Mediterranean style of eating is thoroughly advocated because this is a proven fact or evidence-based eating. Half a portion of vegetables, quarter plate of protein, and quarter plate of your basic carbs. And physical activity per se, when we talk, sedentary behavior is defined as any waking behavior that requires low energy expenditure, such as prolonged sitting, as we discussed a bit before. Software professionals, if you see, if they work from home, minimum of 12 hours, maximum of 14 to 16 hours, they sit in front of the system. So where's the time for them to eat, walk, do exercise? They become totally sedentary. Around 60 to 80% of the people around the world lead a sedentary lifestyle. And sedentary activities lead to obesity, cardiovascular disease, diabetes, colon cancer, high blood pressure, osteoporosis, lipid disorder, anxiety, depression. And how do we advocate physical activity? Because physical activity will help them reduce fat and increase muscle and bone mass. And physical activity in the form of exercise combined with, restricted calorie diet has an added advantage of reducing blood pressure, improving glucose tolerance, lipid profile, insulin sensitivity, helps long-term weight maintenance, decreases risk of comorbidities, and improves self-esteem and well-being. So it is important that as dietitians or healthcare professionals, if we talk to patients who are obese, combine lifestyle, whenever we talk about lifestyle, it is diet, exercise, and behavior, which is very, very important. To sum up, lifestyle modification per se, it is lifestyle behavior, eating behavior. The time of eating is also very, very important. Circadian rhythm has to be proper, and nocturnal eating should be discouraged. Instead of intermittent fasting, maybe you can tell them 10 to 12 hours you eat, because 8 hours or 6 hours of eating pattern becomes difficult for people to sustain in the long run. So 10 to 12 hours is pretty cool for people to adapt. Maybe start your day by 8 o'clock, finish your day between 6 to 8 p.m. Your dinner or the early supper should be over. Improve on physical activity, eating disorders should be addressed, stress, depression, body image, all these improves with lifestyle modification, and overall self-confidence, self-esteem, and quality of life gets improved. And if this doesn't work, then doctors move on to pharmacotherapy and bariatric surgery. So which dietary pattern have evidence of advantage? So this is a guideline which was published in 2018 by Diabetes Canada, wherein they had done a lot of research with different dietary patterns, including Mediterranean diets, vegetarian DASH diet, and Nordic diets, low carbohydrate diets. That's what I'm going to talk to you in the next few minutes. Mediterranean diet, the most popular diet, globally advocated, which has been proven very well. And, it's a research proven diet. It's a traditional plant-based diet, primarily refers to as plant-based diet prescribed or described in 1960s. General features being high consumption of fruits, vegetables, legumes, nuts, seeds, whole grains, and high to moderate consumption of olive oil as the principal source of fat, low to moderate consumption of dairy products. Normally what we advocate is a low-fat dairy product, and fish and poultry are part of the meal plan, but low consumption of red meats, and moderate consumption or low consumption of wine also is advocated. So we do studies have proven remission of diabetes or reversal of diabetes with Mediterranean diets. And we do find that the acute MI or CV deaths are also reduced if patients are consuming Mediterranean diets along with nuts. It has a good impact. That's why at least 30 grams of tree nuts are advocated. Same way we do find in cardio-preventive trial, we do find that the ischemic stroke or revascularization and MI deaths were lesser with Mediterranean diets. And next comes one more systemic review wherein they had looked at more than 1 lakh patients, and it is about 66,000 events. And what they found was there was a decrease in cardiovascular disease by 38% and cardiovascular mortality by 33%, and coronary heart disease decreased by 52%. See, it's all big percentage. So, it is so important for us to understand the importance of Mediterranean diet. You have to personalize it according to the preference and style of eating of the patient and provide it. Nordic diet is a dietary pattern high in plants. So globally, if you see, people are moving towards plant food. And in Indian diet, we are moving towards Western way of eating, right? That's where we are going wrong. And this diet also advocates whole grains, fruits, vegetables, nuts, fatty fishes. And we do find that there is a good outcome in cardiometabolic outcomes in this particular Nordic diet, wherein we find that there is a decrease of 10% LDL, decrease of 10% non-HDL, and decrease of 10% apoprotein. Insulin, plasma insulin is decreased, body weight of 2 kg, and 0.9% kg per meter square of BMI, and waist circumference by 2.2, which is quite a good number. It's between 6 to 96 weeks, approximately 18 weeks they have followed up. And in one more study, Nordic diet, we do find there is a decrease in cardiovascular disease. Mortality decreased by 26%, which is quite a good number, right? And 13% decrease in stroke and 9% in diabetes. Now, it has an impact on blood glucose, blood lipids, adiposity, blood pressure, inflammation. So we do find there is in the longevity, because as Indians, our percentage of vegetarians in India is quite high, and compared to global population, we do not consume non-vegetarian food as global people or Westerners, wherein in all 3 meals they have non-vegetarian source. But in Indian setting, if you see, even weekly once, if we consume non-veg, we call ourselves non-vegetarians, right? So plant-based diet, flexitarian, people do eat dairy products, eggs, small quantity of meat, poultry, fish. Pescatarians, dairy foods, eggs, fish, seafoods, no meat and no poultry. Vegetarian and lacto-vegetarian, dairy products and eggs are okay. Vegans, absolutely no animal food. So there can be healthy vegetarian diet and less healthy vegetarian diet, wherein you do find a lot of juices or carbonated beverages, refined grains as part of the meal plan. So this is a systemic review which analyzed 644 9 trials and 644 people, and the follow-up was about 12 weeks. They did find there is a bit of reduction in the HbA1c and fasting blood glucose, 5% reduction in LDL, 5% in HDL, about 2 kg weight loss, 3 centimeter of waist circumference reduction, which is quite good, appealing. And we do find that the CVD mortality or the coronary heart disease mortality reduced by 20%, and overall coronary heart disease per se, the prevalence reduced by 28%, which is quite good. Moving on to DASH diet, this is a diet that is advocated for lowering the blood pressure, which advocates more of whole grains, vegetables, fruits, low-fat dairy products, and fats and oil. The overall daily serving is reduced to 2 to 3 servings per day. And meat and poultry, 6 or less than 6 weekly servings, encouraging them to have more of nuts, beans, dry fruits, peas, and less of sweets and sugars. And we do find in this, there was a reduction in systemic blood pressure and diastolic blood pressure, reduction in total cholesterol and LDL, reduction in HbA1c and fasting glucose also. Though the reduction in body weight is just 1.4 kg, but it did have an impact on overall cardiovascular, system. So 20% reduction in CVD and CHD, 21%, stroke by 19%, and diabetes by 18%. So low carbohydrate diet, this is one of my favorite diets because you need to understand there is a definition for prescription for ketogenic diet. What we call it as very low carbohydrate diet. The grams of carbohydrates per day is between 20 to 50 grams. So it's about less than 10% of energy from carbs. And low carbohydrate is less than 130 grams. And moderate carbohydrate diet is between 130 and 230. High carbohydrate diet is more than 230 grams per day, which is roughly about more than 45% of the carbohydrate percentage from energy. Okay. So high carbohydrate diet is what we all have as Indians, because we eat predominantly carbohydrate rich food, whether it is rice or chapatis, right? So correcting people who are diabetic becomes a challenge. And there are studies which tells you that there is no difference between, low carbohydrate diet and high carbohydrate diet. This is a particular study which was published in 2009 by Henney, wherein he says that there is no difference between low carb and high carb. And, they did find that there is a difference in the LDL and apoprotein when, in the follow-up of 1 month and 6 months in low carbohydrate diet, there is a drastic decrease from baseline compared to high carb diet. And we did find, in this cohort, there is a difference in the mortality also in low carb versus high carb. And what they finally concluded saying, the difference in all these mortality was basically because of the plant-based source of carbohydrate. Both high and low percentage of carbohydrate diets were associated with increased mortality, with minimal risk observed between 50 to 55% carbohydrate intake. So low carbohydrate dietary pattern favoring animal-derived protein and fat sources like lamb, beef, pork were associated with high mortality compared to plant-derived protein and fat intake from vegetables, nuts, peanut butter, whole grains, wherein they did find a lower mortality in these patients, suggesting that the source of food notably modifies the association between carbohydrate intake and mortality. So whenever we prescribe low carbohydrate diet, we should ensure that the saturated fat content from animal sources are reduced so that it has a better impact for patients, especially when we talk about cardiovascular mortality. And this is a summary of low carb diet, which is advocated by so many associations across the globe. Okay. So whether it is American Dietetic Association or Diabetes Australia or UK, they do advocate a low carbohydrate recommendation for patients with, diabetes.